Okay. Where does this go?
I can make it longer if you want to.
Oh, no, that's okay. I just don't want to. Okay. Maybe I'll hold it that way. I won't pull it down if I get up. So, okay, should I wait a minute or two or go ahead?
Sounds like there's some people for first time, so we can give it a couple minutes.
Testing, testing. Is it? Oh, okay, great.
All right, guys, happy Friday. Welcome to Dr. Gail Reid. Gail Reid is one of our infectious disease doctors, and she's going to be giving us a lecture on antibiotics today.
So welcome, thank you. And please feel free to, actually, I guess I'll put this on so I don't have to hold it the whole time. Please feel free to ask questions in real time. When I try to wait until the end of a talk, I always forget what my question is. So don't hesitate to just interrupt and ask the question. I'm sure if you're thinking it, probably other people are thinking it too. No question is a stupid question. It's better to ask the question than assume that you know the answer because you feel like maybe other people know, probably they don't also. So anyway, I'll go ahead and start. I'm going to talk about some principles of antibiotic use, and I hope this is helpful. I hope it's not me droning on and not being of any help for you all. But if you have questions, how do we do this? Do we just hit the down?
I'll fix it.
Okay, thanks. If you have questions after this, please don't hesitate to contact me as well about anything. Okay, great, thanks. So again, I'm just going to talk about antibiotics and the principles of their use. Just as a reminder, we haven't had antibiotics that long. 1928, Alexander Fleming actually discovered penicillin by accident, and it took another 10 years, so like 1939, around 1939, before they actually extracted the actual drug and developed it as they actually had to extract it. So they had to grow a lot of the mold to be able to utilize it to treat infections. So that's a whole decade. So we really haven't had antibiotics except since the late 30s when sulfa was also discovered and developed. So it's less than 100 years actually that we've had antibiotics. And the thing that was so fascinating for everyone was that it killed these bugs and treated infections to the point where people thought that that was not going to be a problem anymore, which we obviously know is not the truth. But it did make a difference in partly our soldiers coming back from World War II, because historically infections killed a good 30% of soldiers in any given war, at least. And so what we saw after starting to develop antibiotics, and that's the top half here, is that shortly after an antibiotic is put on the market and utilized, within 10 years, and actually that time has shortened, we actually start to see resistance developing. So with the advent, and let's see if this actually works, of like the sulfonamides, which was in the 30s, we see in the 1940s resistance to sulfonamides. The same with penicillin, and the story just continues. Now in 2000, linezolid came on the market, and by 2003, approximately, we actually see linezolid resistance. And daptomycin came on the market around that time, and by 2005, we start seeing daptomycin resistance. So the bugs, we think we're getting smarter, but the bugs are just as wily, if not wilier than we are, and outsmarting us to some degree. So we have to be judicious about what we're doing with antibiotics. That means viral infections, we don't give a Z-Pak for a cold. Historically, we see, I still see it all the time. Give them a Z-Pak. that's really not helping. The patient might feel better because in their mind they're better, or their cold is just going to get better because it's the natural history of a cold, or the natural course of a cold. And some of these antibiotics, like azithromycin, have anti-inflammatory properties. So patients will feel better because you gave them a Z-Pak because the inflammation has calmed everything down. So that's not a reason to give a Z-Pak for a cold. So I have two cases, and forgive me, I have it backwards. I have to fix that. But they're basically two cases, two different patients, both 54-year-old men, admitted for staging of non-Hodgkin's lymphoma. They both spike a fever to 39 degrees. One is fairly shortly after admission. The other one is a week into the hospitalization. And they have different symptomatology. One of them has no symptoms, and his physical exam and imaging are negative. But the other one, who's 1 week into the hospitalization, he has symptoms. He's coughing, he has bronchi on exam, even if his chest x-ray is negative. So the question is always, what do you do next? Are both of these infections? Okay. Is either one an infection or something else? Remember, he's got lymphoma, so it could be the lymphoma causing fever. So what you want to know or think about, and you may not know the answer, but at least think about it before you start an antibiotic, is this really an infection, or am I concerned that this is an infection? Is it screaming at me? Or is it more, it can be subtle, but is this an infection? And if it is, do I need an antibiotic? Is it an infection? Is it a cold? And that's it, and they don't need an antibiotic for that? Or is it something else, like a pneumonia, where they need an antibiotic? And if it is an infection where I feel that they need an antibiotic, where is that infection? And that helps me determine what type of antibiotic or what antibiotic I will use and how, okay? So just remember, fever doesn't equal infection. We get called all the time about a fever. Someone spikes one fever and there's no workup done, okay? A lot of times a fever is due to an infection. Absolutely. I'm not saying it isn't, and we won't say that it isn't, but just keep in mind, remember, drugs, medications can cause fever. Other conditions can cause fever, clots, people who have a PE, people who are having even seizures, they can develop a fever because of what's going on with the seizures. Pancreatitis, malignancy, all of these things can cause fever. There's so many reasons for a fever. So you want to do a full workup and not just for infection. Also keep in mind that people can have an infection and not have a fever. We see them with hypothermia, okay? We see a lot of immunocompromised patients here. If you're interns, you may not have seen it yet, or maybe you have, but we get a lot of immunocompromised patients on steroids and other immunosuppressive medications, and they may not spike a fever, okay? So that's also something to keep in mind. Then you also want to get a good H&P and review of systems, because that can really help you. Sometimes the patient will tell you what's going on. Oh yeah, I had this before when I had blah, blah, blah. And you may have the answer, or at least possibly have an answer. So it's important to do an H&P, look for any subtleties of the H&P and the review of systems, okay? Particularly a review of systems and a history, because that's very, very important. And then of course, laboratory studies, but the H&P can really help you in determining what laboratory studies you want to do. If they're having a cough and they've been around sick people who had pneumonia, then you're going to want to get a white count and a chest x-ray. Okay, so that seems pretty obvious, but I can tell you right now, we have a lot of people with pneumonia and we don't get sputum cultures, we get a urine. And that does not help me what's in their urine unless that urine's going into their lungs. So, so think about what you're concerned about and culture it, okay? That's really important. And the reason is we have all these wonderful, we have an amazing micro lab. It's probably one of the best, if not the best in the city. And even though we're not in the city, I guess, but we have carious testing, which we don't do on everyone. We have PCR of the blood and the CSF, etc. But even when we have an organism identified, we need cultures. When we have someone with nocardia, I still don't know what antibiotic it's susceptible to. I need to get cultures so that we can do susceptibility testing, okay? So it's really important to still get cultures, even if we're doing these other tests, to diagnose earlier. So again, H&P, review of systems, I can't tell you how important that is. You can find out some crazy stories about people from just doing a really good H&P. I had a patient who was being worked up for a lung transplant, and his wife was with him, and I was asking him about animal exposures. And I said, do you have any pets? No, I don't have any pets. Are you around any animals, exposed to any? Because that would have been the end of it, right? You asked, do you have any pets? No. Well, his wife takes care of sick wild animals unofficially. They have a barn, and there's a wild squirrel living in their dining room while it's healing. So it's like running all over their dining room table, doing who knows what in his food. And I'm like, are you kidding me? So the way you ask questions for an H&P is very important, open-ended and not just focused on, do you have any pets? They may not, he doesn't count them as his pets. They're not his pets. But he's got a wild squirrel living in his dining room, which is kind of gross, but anyway, so it's really important to ask that. I've asked people in terms of getting a history of exposure to tuberculosis. If you say, have you ever been to jail? They say no. But if you ask them, have you ever spent time in or worked in or volunteered in jail or a homeless shelter? They might say yes, because they're a prison guard. I've been a prison guard for 20 years. Why didn't you tell me that? Well, you asked me if I had been to jail. No, but I worked in jail. You didn't ask me that. They're very concrete sometimes. So you want to ask them, homeless? I've never been homeless. I worked in a homeless shelter for 10 years volunteering, but you didn't ask me that. So it's important to kind of tweak your questions. And you'll see this when you ask someone if they smoke. Do you smoke? No. Have you ever? Yes. When was the last time you smoked a cigarette? Yesterday. So, right, you still smell the smoke on them. So yeah, they can be very like concrete and focused. And once someone quits smoking, they're like, I don't smoke anymore. They're proud of that. And that's good, but it doesn't mean that they don't have issues from the tobacco. So anyway, that's another story. So do you need an antibiotic? Again, if it's an infection, is it a viral infection? Is it a fungal infection? We see a lot of fungal infections. Sometimes just a simple bacterial infection like a paronychia, a little abscess, you squeeze it out, and that's really what you want to do, is just get all the pus out, and you may not need oral antibiotics. You could probably even do something topical if you needed to. So is the antibiotic really going to be effective if it's a non-bacterial infection, like a viral infection, or a small abscess that needs drainage? Or is it going to be beneficial? Is the side effect from the antibiotic going to be worse than whatever is going on, the little abscess that they have that you can drain? Do you really need to give an antibiotic for that in addition? Because maybe they have a sulfa allergy and they get Stevens-Johnson syndrome. Well, how did that help them? Okay. And then of course we have to think about, if it is bacterial, is there resistance where someone can then have a side effect from the medication's not helping, and it hasn't made a difference at all. Also, if someone has E. coli H1, 0157H7, I'm thinking of H1N1, I'm thinking of the flu right now. You don't want to give people, if they have diarrhea from this, you don't want to give them an antibiotic because it could actually make it worse. It can lead to upregulation of the toxin by the bacteria, and they can actually get hemolytic uremic syndrome and things like that. So again, thinking about what the infection is, and am I actually going to hurt someone by giving them an antibiotic? Okay, it's really important to think about that. So if you've just determined that they need an antibiotic, they look septic or they just look really sick, and this you think this is a bacterial infection, and this goes also for fungal infections. If you do more ID, you can tease that out a little bit more. But where is the infection? We need to know that, because that's going to tell you what the most likely organisms are. So what are the most likely treatments? And it also helps us determine dosing and the type of drug, because some drugs can treat an organism, but if it doesn't get to where the infection is, it doesn't matter. Okay, and I'll talk a little bit more about that. So endocarditis, cellulitis, periorbital cellulitis, meningitis. This is actually from an autopsy that I worked on. Some of these are pictures of patients that I actually saw as well, not all of them. But we have a pneumonia, a liver abscess. It's really important to have some kind of idea of where the infection is to help you delineate what the organism might be until you know what the pathogen is. And so when you have an idea of where the infection is, oh, they're coughing, chest x-ray shows a pneumonia, then what are the common pathogens, particularly for that patient? And that helps you determine what antibiotics to use and how to use that antibiotic. And I'm going to talk a little bit more about that because depending on where the infection is, you may use a higher dose, more frequency, or a different drug than if the same organism were causing an infection somewhere else in the body, okay? So in terms of common pathogens, we know historically, based on epidemiology, case series, case reports, that certain patient populations are at increased risk. Patients with liver disease are at increased risk for infections, particularly fungal infections, okay, because the liver is part of the reticular RAS, and so it clears some pathogens from the blood. And when we see patients with severe liver disease, they're at increased risk for things like cryptococcal infection, even without having a transplant, okay? So depending on the patient, they're also at risk for things like Vibrio infection and like Vibrio vulnificus, et cetera, and other fungal infections, mold infections. Their age, you know, we always see little children, newborns are at increased risk for certain types of meningitis versus older patients who might be at increased risk for other types of meningitis. Comorbidities like diabetes. Patients who have diabetes, we have to worry about fungal infections, we have to worry about Pseudomonas, et cetera, okay? So knowing what their comorbidities are is very important as well. And of course, I do a lot of transplant ID, so knowing that they had a certain type of transplant, if they had treatment for rejection, what their immunosuppression is like, that's very important as well. What environment are they coming from? Was this are they coming from a healthcare facility or the community? Have they traveled? And where to? I always ask, where have you ever been in your life when I'm doing a pre-transplant evaluation? No one ever wants to tell me. They just want to tell me what they've done in the past 2 years, which is nothing because of the pandemic, but you know, animals and pets, again, animals that you've been exposed to. I even ask, if you have pets, are they up to date on their vaccinations? Okay, that's very important. When someone has, well, I'll talk a little bit more about certain types of organisms with pets because that's interesting and important to know. But in terms of identifying, again, I mentioned we have all these tests that we can do that give us information pretty quickly, but cultures are also still really important. And I would say, if ideally what we like is tissue or pus, not on a swab, but in a sterile cup, because some things don't grow from swabs, and so you'll never detect them. We have PCR, MALDI-TOF, direct fluorescent antibody testing. We have something called a Carius test, which is cell-free DNA. So it can detect like 1,200 different pathogens, but it does not detect RNA viruses, okay? It'll detect DNA viruses, and it's very sensitive, so sometimes it'll detect things that aren't really causing an infection. So then when we're deciding on what antibiotic to use, we often will start empiric and then do pathogen directed once we have an idea of what the pathogen is. But empiric can still be pathogen directed. Example, community acquired pneumonia. We start empirically with ceftriaxone and azithromycin, or we should if it's community acquired pneumonia. And that is still to some degree pathogen directed because we're thinking of the most likely organisms causing community acquired pneumonia, right? Strep, pneumo, Haemophilus, things like that. And so this is going to hit those. Chlamydia, things like that. But once you know what the organism is, and then you can tailor better, and maybe you won't cut everything off. Like if you know that it's Haemophilus or strep pneumo, you may keep the ceftriaxone but stop the azithro, okay? So you will tailor or switch as you know what the organism is and what the susceptibilities are. And then think about intrinsic resistance and acquired resistance. These are things that we think about. Is the organism automatically not susceptible to what the patient is on? Or is it possible that they are susceptible but it's also possible that they could have a resistance, like staph. Staph inherently can be treated with amoxicillin, ampicillin, unless, like if it's MSSA, but if it's MRSA, then it can't. So that's more acquired resistance. And it's important to understand your local hospital antibiograms. So some locations have strep pneumo 30% or more resistant to penicillin. And that's important when we're going to treat, even with ceftriaxone for a meningitis, because you have to jack up the dose. And if they have like a strep pneumo meningitis, and your hospital has a lot of a high percentage of resistance, then you want to add something like vancomycin until you have susceptibilities back to know that the ceftriaxone is effective. So if your hospital doesn't really have resistance, then you don't necessarily have to add vancomycin. Yes.
How often do you guys check for the resistance with different pathogens in the hospital?
We check.
I guess how often do you update that?
So the microlab does that. Oh, you mean the antibiogram?
Yeah.
Oh, good question. The antibiogram is over a 2-year period, usually because you want to have enough pathogens to make it reliable. So the other problem with our antibiogram, just in general, is we get a lot of transfers from all kinds of hospitals. And so we're kind of bringing their organisms. We got people who are, somewhere Podunk Town, Illinois, for like a week or two, and they have liver disease, or they're getting evaluated for an LVAD and a heart transplant now or something else. And then they transfer them to us. So then we're picking up those as well. So, and then we may need to do more than one antibiotic. Tuberculosis is a fine example. If we're not sure, again, pneumonia, community-acquired pneumonia, we'll do ceftriaxone and azithro until we know what the organism is. And we always have to think about patient allergies, okay? We've seen some really bad outcomes with people having a bad reaction to medications. So you want to keep that in mind and keep an eye out for it. And then the other important thing to think about is, when do you start? Do we need to start antibiotics on everyone immediately when we know they have an infection? No. Okay. If they're septic, if they're unstable, absolutely. If someone has an abscess and they're pretty stable, they've been admitted, they're going to the OR to get it drained or, get some cultures, we don't have to put them on antibiotics till their peri-procedure, because if we give them antibiotics and they're on it for however long before the abscess is drained, we may not grow the organism. And then you all will be asking me, or someone will be asking me, well, what do we use to send them? What do we send them home on? And how long do we treat? And my answer is, I don't know. I don't know what they have. So then we end up having to use broad spectrum antibiotics, which is not good. Okay. So those are things to think about. If the patient is looking unwell, if they're unwell, and certainly with meningitis or anything like that, yes, absolutely, you want to start antibiotics immediately, okay? If you're concerned that they're septic or bacteremic, you get some blood cultures really fast, and then you start broad spectrum antibiotics. That's totally reasonable. But sometimes we don't always have to do it right away. If they have an osteomyelitis and they're stable, they're going to the OR for debridement, they can get what they need to OR, but they don't need to be started on antibiotics right away if everything is stable and they're not septic, okay? So the dose is going to vary, of course, based on the antibiotic, the organism, and the location of infection. CNS infections, endocarditis, we're jacking up the dose and the frequency, okay? And you want a cidal drug, a drug that kills. A cellulitis, maybe not as much. So it depends, okay? And I'll tell you, MRSA, I'm pushing the dose, okay? Like, especially with daptomycin or something like that, MRSA, VRE, you want to push the dose more, because Staph aureus is really aggressive. And I don't know how long you've been seeing patients on the wards, but we have a lot of Staph aureus bacteremia, endocarditis. So it's pretty scary. Sometimes it's weight-based. We have to look at their renal function and their hepatic function in choosing the antibiotic and in dosing it, okay? And then deciding on IV or oral. So a lot of the drugs don't have the same bioavailability PO as they do IV. Some of them do, like quinolones, okay? It's pretty similar. Linezolid also. but many of them don't, particularly the beta-lactams. They don't. Their half-life is short, and so they clear pretty quickly. And they don't get good blood levels when you do PO versus IV. So with things like meningitis and endocarditis, we're giving IV. But if you were treating even like an osteo, or even like E. coli bacteremia in someone, if you end up giving them a quinolone because it's susceptible and they don't want to take IV, or they're a IV drug user or something like that, then you could potentially use oral like a quinolone because it gets good bioavailability. But beyond that, you'd have to use IV, okay? And then the duration, I have no idea. It's going to depend. Cellulitis could be 5 days, could be 2 or 3 weeks, depending on how they resolve. Some infections like endocarditis, I'm going to do at least 6 weeks, if not longer, depending on what's going on with them. If they have an abscess or something, abscesses, that could be anything. It depends on when the abscess resolves. And I may start with IV, but as it shrinks to a small enough size, I might be able to switch to PO depending on the organism. So it will depend on how the patient is doing. A lot of times we'll do 2 weeks for bacteremia, although with staff, a lot of times I do 4 weeks. There's some people looking at shorter durations even for bacteremia. So you may see that as well, but I wouldn't do that unless ID recommends it. And it's going to depend on the organism, okay? So pneumonia, common pathogens, of course, I'm sure you're aware, strep pneumo, especially H flu. We don't see H flu so much in kids who've been vaccinated, but we do have a large group of people who don't want to vaccinate their kids. So we're going to see yummy things like H flu, measles, all that fun stuff. But we also can see atypicals like mycoplasma, Legionella. Always look for Legionella. We're seeing more Legionella. And that is not treated with ceftriaxone. We have to use like azithro or a quinolone for that. And we have a Legionella urine antigen, but it misses about up to 30 to 40% of Legionella is not detected with the antigen. So you want to get some cultures too, okay? And then of course, lots of viruses. Need I say more? We've been having to deal with one for the past year and a half. If they've been in the hospital, we have to worry about gram negatives, especially resistant gram negatives, including Pseudomonas and Staph aureus. And always think about tuberculosis. So I have seen several patients who come in to the emergency room and they've had a fever, they have a pneumonia basically, and they've come like every month for the past 4 months, okay? And they get azithromycin, they get second generation cephalosporin they're sent out on. They start feeling better after a day or two, but then they come back the next month. And then finally someone does a CT and they have a honking cavitation. And guess what? They've had tuberculosis all this time, or they've had histoplasmosis or blasto, that's Chicago disease. So again, the Z-Pack, they feel better and then they go home and then they keep coming back. When that just doesn't make sense, why is someone getting pneumonia constantly? Why? Then look a little further and be concerned about these fungal infections and tuberculosis, okay? And then think of some of the less common pathogens when you have patients who are immunocompromised. Pneumocystis, non-tuberculous mycobacteria, nocardia. We just had I'm seeing a lot of heart transplant patients who have had mold infections, and we just had one who had a mold infection that he's a farmer of soy, and this mold actually infects soy plants. And he had it on his hand, and then he had it in his lung, and he grew it really fast. They couldn't even identify the mold right away. The Carius identified it. It was called macrophomina. So we started him on treatment, and he seemed to get a little better. Then he's getting worse again, and he's coughing and having some fevers. So we got another sputum culture, and then he grew nocardia. So he had pneumonia from both organisms, sort of overlapping, not completely. I think that the mold was first and then the nocardia. And we detected them initially from Carius, each one, although the first Carius didn't detect nocardia. So consider, if something's not making sense, then think about maybe they have something else, okay? Or a couple things going on. And we do see histoplasmosis, blastomycosis, aspergillus, cryptococcus. We don't see as much coccidioides because that's more from the Southwest. Travel, This was before SARS-CoV-2. And so clearly, historically, coronavirus has caused problems for humans even before COVID-19. And so you want to find out where they've been and what could be going on with them, okay? And then of course, animals, if they've had animal contact and they may not even realize it, if they go to a cabin in Colorado or somewhere out west, they could have been exposed to plague or hantavirus from rodents, tularemia. There are actually rabbits in Cook County that are infected with tularemia, by the way. I can't wait. I mean, not I can't wait, but I'm thinking that I might be seeing tularemia at some point. So I'll word it that way. I don't want anyone to have tularemia. So when we see pneumonia, for community-acquired pneumonia, again, third-generation cephalosporin and a macrolide. So ceftriaxone and azithro, that's the main thing. You can use a fluoroquinolone, but always remember the black box warning with for fluoroquinolones, not just with the tendon rupture, but also now we have issues with their glucose. The aneurysms, they can have aneurysm rupture. And in older patients, they can get very confused and disoriented. So you want to be careful with quinolones. I do not like to use quinolones for a long period of time in a lot of these people, especially people who have a history of smoking because of the risk of aneurysm. If they've had a recent viral infection, then and so they seem to be getting better and then they get worse again. Think about staph, especially MRSA if they've been in the hospital. We see this, it causes empyema, causes necrotizing pneumonia. So just keep that in mind for someone who has like a viral infection. Healthcare associated, and the staph can actually occur from community, okay? So they have a viral infection. Influenza is notorious for this, where they have the flu, maybe they were at home the whole time, they get over it, then they start getting worse again, and they come in and they have a bacterial pneumonia. Staph can often do this, and then it can be a severe necrotizing pneumonia. It doesn't have to be MRSA, it could be MSSA. Healthcare associated, you want to use an yes.
Question on pneumonia is how reliable is the mercenaries in terms of like...
Thank you. Yeah, I mean, I guess you can you can trust it more for a pneumonia than for other infections, okay? So I have seen like an ulcer on the foot or, you know, like an intra-abdominal infection that had MRSA, but their nares was negative. So I don't rely on that 100%. If it's a rip-roaring pneumonia, then you'd expect that the nares should be positive if it's MRSA. But if they're really sick, I keep the vanco until I know what the cultures are showing, what the cultures show. And no one can fault you for that. You just want, because you don't want to stop it and then it comes back that it's MRSA and then you have to restart it and the patient's getting worse again and all that. It's, you know, but yeah, for certainly for other infections, I don't trust it. So I think it's more helpful just for isolation issues, like if someone's like sneezing on their roommate or something. So you want to, for healthcare associated, you have to be concerned about MRSA and Pseudomonas. So you want an anti-pseudomonal penicillin. The only one we have available is Zosyn or Piperacillin tazobactam, or cefepime, which is a 4th generation cephalosporin, or a carbapenem. And if they're immunocompromised, you also want to think about pneumocystis possibly in them. So you might need to test for pneumocystis or consider trimethoprim sulfa or antifungal therapy. Urinary tract infections, of course, enteric gram negatives are common, and enterococcus we also see. And if they're from a healthcare facility, then you have to be worried about resistant gram negatives in particular. So ESBL, E. coli, etc. And always keep this in the back of your mind. You're treating them for a UTI and it's not getting better. Check for a sexually transmitted infection, okay? Get a urine GC chlamydia. This happened just last year where a patient was, she had some dysuria. They were treating her. I think she had Keflex or something. I don't remember now. And she continued to have the dysuria. And so we got a GC chlamydia and it was positive. She was a transplant patient too. And her story was, oh, I don't do anything. That's what she said first. And then when we said, you got gonorrhea, she's like, well, and then she was like, texting whoever she thought gave it to her. So she was going by the date. So I guess she hooked up with a lot of people. So anyway, check for that. Check for sexually transmitted infections. They're going to tell you they didn't do anything. They'll say it's non-penetrating, what have you. Oral doesn't count. And it's not just for urinary tract infections. I had one last year who had a sore throat and he had a rash. For a month, he had a rash. And they kept checking him for measles and his IgG was positive because he was vaccinated. But they kept saying he had measles. This was like a guy in his 20s or 30s. And he's MSM, not that it matters, but they didn't, he had a sore throat. He went to the ED. They did a strep test. It was negative. So they sent him to me. And I was like, okay, what do you do? Well, he performs oral on people. So I did GC chlamydia of his throat and it was positive. And I tested him for syphilis and that measles rash was syphilis. So sore throat, urethritis, dysuria. If you're not detecting something, look for an STD, okay? Because it's probably there, or it could be, all right? So just keep in mind too that with UTIs, we see trimethoprim and quinolone resistance. So you wanna get susceptibilities, and which they do when you get cultures, okay? And then the other thing to keep in mind is if they do have a UTI, do they have cystitis or do they have pyelo? Because the treatment is different. With pyelo, you're going to most likely do IV antibiotics unless you can do a quinolone, and you're going to treat longer. You're going to treat for 2 weeks, okay? So that's important. With cystitis, you can even use certain antibiotics that the organism says it's resistant to. So for example, well, organisms didn't say it, but the cultures say that. So VRE in the urine, you can actually use ampicillin, because the ampicillin gets such high levels in the urine that it usually overcomes the resistance, okay? So you use ampicillin for ampicillin resistant, vancomycin resistant enterococcus, okay? You can't do that for ESBL though, okay? So it's important to know what the organism is, where it is, and what you may be able to use. And that's the example I was talking about. So prostate also, we often see, gram-negative rods, but also consider colonic flora. Okay, so enterococcus, even sometimes yeast. So if someone's not getting better with antibiotics and you're hitting them with a lot and you're hitting the most likely pathogens, think about yeast. Yeast could be there. Even in polymicrobial infections, a lot of times they don't grow as easily when you have a polymicrobial infection. And then consider staph and strep as well. Meningitis, again, common pathogens that we see. You won't see Haemophilus as much because of vaccinations, but you can see it in some older people who never got vaccinated, as well as children whose parents refused to vaccinate them, okay? And then of course we can see viruses. West Nile, they're finding West Nile now. We have a patient now that we're trying to get the outside LP results for them to check for West Nile. So just keep that in mind as well, West Nile virus, especially for immunocompromised and older patients. And then thinking about their age, the extremes of age, really young, really old, then some of the enteric gram-negatives. And in pregnant women and people who have liver disease, immunocompromised patients, think about Listeria, okay? And we see this, I had a pregnant woman who went into labor a month early, baby was born with Listeria Bacteremia, and she had Listeria Bacteremia. She was from Mexico, I think, and her family came up, they were anxious for the baby, they were excited for the baby to be born, and they brought fresh cheese that wasn't pasteurized and gave it to her, and she got Listeria and went into early labor. So that's something I talk to my immunocompromised patients about. Pasteurized food. Don't get fresh juice from Mariano's that they just squeezed yesterday, because it could have Listeria in it. Sometimes I drink it, but I'm not immunocompromised, so I try not to. But, and cheese and other things like that, you want to have it pasteurized, okay? So that's not the only thing you can get from it. You can get mycobacteria from it as well. And always think about not just HSV and VZV, but other viral meningoencephalitis. And with immunocompromised people in particular, cryptococcus and tuberculosis, we can see. Okay, question? Did someone have a question? No, okay. So you also have to think about penicillin resistance. I mentioned this briefly with the strep pneumo and allergies. And we look at MICs. Sometimes you might see when for like strep pneumo and some other organisms, it may have two different MICs, and one is for bacteremia and one is for meningitis, because they'll do for those organisms that are known to cause, like Neisseria and strep pneumo, known to cause meningitis too. We need to know what the MIC is for if they have a bacteremia or if they actually have a meningitis, because the dose can be different, and you may be able to use it to treat a bacteremia, but you may not be able to use it to treat a meningitis, okay? Because you have to go up on the dose, and if the MIC is too high, you may not be able to reach that and overcome it. We do higher doses. For example, ceftriaxone, you'll do 2 grams Q12, whereas other times you might do 1 gram Q24 or 2 grams Q24 for other infections, okay? And we're going to do IV for obvious reasons. And we really try to do cidal drugs. However, the caveat with that is it's going to depend on the organism. So if there's Rocky Mountain spotted fever and they have meningitis, we're going to do doxycycline, which isn't necessarily cidal, but that's the treatment of choice. The outcomes are better. So it to some degree depends on the organism. But if you see Rocky Mountain spotted fever here, please call me, okay? So the more common, most likely ones that you'll see, you want to use a cidal drug. Yeah.
Briefly go back to the MIC, how they have 2 different MICs.
Yeah.
So I didn't quite know.
Sure. So when they do the MIC, the minimum inhibitory concentration, it's what is the lowest amount of this drug in that body fluid, and usually it's for blood, that will inhibit the growth of the organism, okay? And so that can tell us if we can use the drug, because if it's too high, then you can't get enough of the drug into the person's bloodstream to stop the organism, right?
MICs can vary based on the fluid it's in.
For certain pathogens. Yeah, so because the blood-brain barrier is difficult for drugs to get into, and it's such a significant infection for some of these organisms, the MIC might be fine if they have a bacteremia or a cellulitis, and you can get enough of the drug to that area to inhibit the organism, but it can't get past the blood-brain barrier enough to do that. Does that make sense? Yeah. So cellulitis. So common pathogens, again, strep and staph is what we often see, but you can see other organisms. We can see Pseudomonas, particularly in diabetics. If there's like an ulcer and it's super infected, it can lead to a surrounding cellulitis that may have other organisms, including enteric organisms. I know it's gross, but it can get fecal contamination, even microscopically. So that's, especially if it's like on your legs, thighs, foot, etc. Think about potential exposures. Was the patient like fishing, standing in brackish water in the lake? And then he got a cellulitis. He had an ulcer because the boot was rubbing against his foot and then water got into it. And so maybe he's got Aeromonas infection from that. Or if he was swimming in the Gulf of Mexico and he got like an abrasion with coral and he's got Vibrio vulnificus. Or I had someone who was trying to get crabs to eat. He was getting it out of the water and it nipped him and he had erysipelathrix in his blood. So think about that, like what led to this? What was going on before this occurred? Okay. And then a lot of times we'll use penicillins, it depends, or cephalosporins. You'll see people using cephalexin a lot. If it's just a basic strep and staph and it's not MRSA, then you can use something like a cephalexin. You can also use Amsulbactam or amoxiclav, which is the oral formulation. If you're concerned about MRSA, you may want to do vancomycin to start with. Tigecycline I put there, that often I've used that a couple times for polymicrobial infection that doesn't have Pseudomonas, but people don't tolerate that well, and it's IV. So that's kind of more of a last resort. And Piptazo, if you're not sure and they're diabetic and you're worried about Pseudomonas and it looks really bad, you may do that. Okay. Animal bites, and it's not just bites, licks. Okay. I had a patient who had an amputation of his foot, and it was opened up and it was cultured and it grew Pasteurella. And I said, stop letting your cat lick your foot. And he's like, how'd you know I had a cat? And I was like, because it grew Pasteurella, and it was probably from the cat's mouth. Could be from the dog's mouth as well. So the lick, it's not just the bite, but the cute little dog licking the cute little baby, such a cute picture. I hope he doesn't have a little abrasion there, because you could get Pasteurella, Capnocytophaga, okay? That can happen. And for that, I use Unison, Amsulbactam. If they're, if they look toxic or it's causing lymphangitic spread, if it's pretty early, you might be able to get away with something PO like Augmentin, okay? So cellulitis can be an emergency, like when you have neck fash. And so with that, you want to get an MR and you want to get a surgical consultation, because antibiotics alone will not treat it. You also want to make sure that with a beta lactamase, with a beta lactam with a beta lactamase inhibitor, you add clindamycin, and that will stop toxin production. Because if you use the drug, the beta lactam alone, it may start to kill the bacteria, but the ones that are still alive are going to start making more toxin, and that's really what's causing the progression of the necrotizing fasciitis. Okay, that's an ID surgical emergency. And if you are concerned about that, you get an MRI, you get a surgery consult, and when the intern in surgery says it's not neck fash, tell them you want the senior to come and tell you that, especially if the MRI says neck fash. Okay, I've had patients who I had a patient with neck fash, and the intern came. It wasn't his fault, he had never seen it, and it was going up his arm before within hours. This thing is rapidly progressive. Okay, at like 6 o'clock, he almost coded. We had to intubate him in the evening. We called the intern, and he just had a little red area, and they said, oh, it's nothing. And then by 5 o'clock the next morning, I came in, and they were on their second debridement, and that whole arm, there was no skin on it. They were debriding down the muscle. So, and the patient ultimately died anyway. So neck fash is an emergency. But also consider some gram negatives and anaerobes, especially if you're treating for gram positives and it's not getting better, okay? Vibrio Aeromonas, again, like I said, if they're exposed to salt water Vibrio, freshwater Aeromonas. Think about Clostridium and Capnocytophaga with dogs. This one can be an emergency. When people are asplenic, you have to worry about strep pneumo, Neisseria and Haemophilus, but also Capnocytophaga, okay? Because they can become septic from this. And then think about the dose and route. It's just going to depend on how sick they are, if it's getting better with whatever antibiotics you're using, depending on the drug, weight adjustment. And some people 5 days and it's fine. Some 2-3 weeks before you can stop the antibiotics. Then upper respiratory infections, again, aside from like the pneumonia, we think of viruses, but if they have bronchitis, sinusitis, otitis media, then you'll need antibiotics. And I will say for sinusitis, I love Augmentin. People like to give quinolones. Don't give me a quinolone for sinusitis. Augmentin really works because it has really great anaerobic activity as well. So unless there's Pseudomonas in there, then you don't want to use Augmentin because it has no activity against it, okay? And epiglottitis, if you are concerned about epiglottitis, do not even go near their throat, because if you do anything manipulating that, it can close up, and that's it. It's game over, okay? You make sure that you call ENT and you tell them that the patient may need to be intubated immediately, and you're not going to putz around in there, okay? Sepsis, again, uncertain. There's a lot of uncertainty. Everyone in the MICU, everyone's septic. So everyone gets vancomycin. And the consequences of not starting the antibiotics in time are pretty bad. So we get it. But if you're concerned about sepsis, please get the blood cultures and whatever other cultures. If it's pneumonia, then get some sputum or BAL or something, okay? And it's important to know what the organism is if we can identify it, because that can help us determine how long we're going to treat. If there's a need for source control, if there's an abscess, then it may need to be drained. Otherwise, they're just going to develop more and more resistance. And if there's no improvement, maybe it's not the right diagnosis, maybe it's not an infection, or maybe it's the wrong infection, maybe we're barking up the wrong tree. Or maybe they were undertreated. I can tell you, we see this all the time where someone's underdosed. They went into renal failure, now their kidneys are recovering and nobody's adjusted the dose of the antibiotic, okay? Or the timing. I had a patient with cellulitis in the hospital. He was put on clindamycin, it was getting better. They sent him home with clindamycin, Q6 hours, I think, no, not Q6, QID is what they said. So he took it 4 times a day from 8 in the morning till 8 at night. And between 8 at night and 8 in the morning, he wasn't getting anything and it started getting worse again. Go figure. So we readjusted and we did it Q6 hours and it started getting better. So just little things like that can make a difference, okay? Or they could develop a new infection. You treat them for something and they develop diarrhea, C. diff, something like that, okay? Then just a little bit about the drugs, cidal drugs. I talk about cidal and static. Cidal drugs kill. And the tricky thing with this is beta-lactams are pretty much cidal, but there are occasionally situations where a certain organism, it's not cidal against, okay? It may be static, okay? But for the most part, the beta-lactams, penicillins, aztreonam, carbapenem, cephalosporins, they are cidal, they kill. That's one of the reasons we use them for meningitis, plus they get across the blood-brain barrier better than some other drugs. And we use them for endocarditis and things like that, okay? Chloramphenicol, we don't use, but other countries, they use it. And that's only cidal against pneumococcus and Neisseria. Fluoroquinolones are considered cidal, although they, for some organisms, they may be more static. Linezolid is considered a static drug, but against strep pneumo, it's cidal. Daptomycin is cidal and aminoglycosides are cidal. And this isn't something you have to memorize. It's just to kind of give you an idea of why we use certain drugs, okay? And how they may be, some drugs might be more effective than others for certain situations. Static drugs are more like the macrolides, the tetracyclines. Vancomycin is a cidal drug, but it's static against Enterococcus, okay? And then the sulfonamides and linezolid again. And then a little bit about each group. Penicillins, the basic penicillin is good against gram-positives, so including syphilis. That's what the treatment of choice for syphilis, okay? Hefty dose of penicillin. And then as you move up the different groups of penicillins, there's nafcillin, which is like a synthetic, semi-synthetic penicillin, and that is really good against Staph aureus. That's also in that group is oxacillin and methicillin. And then the aminopenicillins, which are ampicillin and amoxicillin. And then with the beta-lactamase inhibitor, that's the with sulbactam. So those have good activity against Enterococcus. And again, some of the gram-positives and some gram-negatives. And some of these with the beta-lactamase inhibitor, it has pretty good anaerobic activity. That's why I use Augmentin for sinusitis. It has really good anaerobic activity, and it actually can be used for like an aspiration pneumonia, okay? And certain cellulitis if there's no Pseudomonas. So the anti-pseudomonal penicillin, Zosyn, hits everything for the most part that the other ones hit, but it also hits Pseudomonas. So it has better activity against some of these more bothersome gram-negative organisms. And then aztreonam, the thing to remember for that is only against gram-negatives. It has no other activity. So we use this when people have a penicillin allergy because the if there's a concern for other beta-lactam allergies, we don't see that with aztreonam, okay? And it only has activity against gram-negatives. So you'd have to use that with something else if you're using it for empiric therapy for like sepsis or something like that. And then the carbapenems are our big guns. So I don't like to use those unless we absolutely have to, because otherwise you're using your neutron bomb when you don't need to, okay? And once you use that, you have nowhere else to go practically. So ertapenem is like the least broad of those. It has no activity against Pseudomonas, so just keep that in mind. And it doesn't have activity against Enterococcus. And meropenem and imipenem, and then there's Dory, which we don't use here. Those have much broader activity. Imipenem we use for nocardia also. We don't use it that much here, but we do use it for nocardia, okay? And they are good for the ESBL gram negatives. And the quinolones we will use for something like stenotrophomonas, like levofloxacin is good for stenotrophomonas, which you can see if someone's been in the hospital for a while and then they've had meropenem or they're on meropenem and they grow a gram-negative bacteremia. Think about that, okay? Think about possibly stenotrophomonas there. And then the big thing with the cephalosporins is the first generations are good for staph and some basic gram negatives. The second generations are really just for anaerobes, so we'll use that for perioperative procedures. Third generation has better gram negative activity in some staph. That's ceftriaxone and ceftaz. Ceftaz doesn't have any staph activity though. Fourth generation is cefepime, and that has anti-pseudomonal activity and good staph activity. And then the fifth, some of the other generations are more for resistant organisms. And none of these has activity against Enterococcus, just so that you know. Daptomycin and linezolid are great for gram positives, particularly resistant gram positives like MRSA and vancomycin resistant Enterococcus. Although we had a liver transplant patient who had VRE resistant to everything because she had abscesses that were not drained. And so the organisms just eventually became resistant to everything we used. So, and then we don't use colistin that often. It's more for gram negatives, and that's kind of when we're kind of desperate. And it's important also to understand the distribution. So the beta-lactams get in just about everywhere. That's another reason we can use it for meningitis. And vancomycin can get through the meninges when it's inflamed, but some drugs don't get everywhere. And something like tigecycline that's IV, you cannot use that for bacteremia. Okay, just because it's IV doesn't mean you can use it for bacteremia. Tigecycline goes into skin and soft tissue very quickly. It doesn't keep good levels in the blood to treat bacteremia. Okay, so just kind of keep that in mind. Linezolid gets lots of places, including the CSF. So that can be very helpful for CSF, for meningitis, like from Enterococcus. And I'm sorry that this didn't show up very well. I think you guys can get a copy of this. And it's just the different sites of infection and some of the more common organisms, pathogens that you would expect or anticipate for these infections. And this can be very helpful if you're on call and you're thinking, oh, they have a UTI, what are the most likely organisms, okay? And then again, some of the emergencies for ID, I've already talked about meningitis, sepsis, necrotizing fasciitis. Malaria is also an ID emergency. You call us, we'll come in the middle of the night if someone has malaria, okay? We have to do a thick and thin smear and arrange to get treatment. Might have to be through the CDC. So that's something that is an emergency that cannot wait until the morning, okay? Rocky Mountain spotted fever. This is diphtheria. Diphtheria is an emergency. The problem is by the time they have this, there's a gray film covering their oropharynx. If you try to cut through it, they bleed and they aspirate. We have a vaccine for diphtheria, but we may see it if people don't get vaccinated, don't get their teeth out. So measles is another one, which there's not much that we can do except isolate people, okay? They have to be in a negative pressure room with measles, okay? Hantavirus, hopefully we won't see, or pulmonary anthrax, tularemia, or plague. But you call us in the middle of the night for these, okay? And then I don't know that there's time if you want to go over with me at some point in the future. There's the Sanford Guide. There's a hard copy book, and you can also get it like for your phone. And I have it on my phone, and it's really great. It can help you when I was a resident, they didn't have it. You know, they didn't have all these smartphones and stuff on them. So I had the hard copy and I had my little pearls in there. But they have great tables that show you susceptibility for not just the common bacteria, but for fungus, for fungi, and for viruses as well. And so that can be very helpful, especially in the middle of the night if you're on call, for different syndromes and organ systems, and for different, even different pathogens, specific pathogens. They have adverse effects, desensitization, and again, like I said, the pathogens, including viruses, antiviral agents that are available, what to do. This tells you, like for Achromobacter xylus oxidans, how to treat it, what are the regimens, and how to dose them. And it even has for the drugs, how to dose based on their renal, on the creatinine clearance, etc. Okay, so for guidelines for treatment of any infections, you can go to idsociety.org, and it has treatment guidelines for various infections. Okay, and then of course the Sanford Guide, which I don't have any investment in Sanford Guide, so.
They have an app. The Stanford guy.
Yep.
It's 30 a year.
Yeah.
Is there like
I'm wondering if the library has it though, where you can look it up on the computer here. The library might have it. Yeah. So for me, it was worth it. Of course, I'm an ID, but if you're going into even like primary care or hospitalist medicine, where you're going to be treating infections, then it's always good to have. So, okay. Any questions? All right, thank you. Sorry I went over. It was a lot. It was dense. I know. It's a lot of information.